When I was first invited to present this, when they asked me to speak about the medical aspects of palliative care, I thought, oh great, I'll have a whole afternoon or day to talk about this, because most textbooks will actually go on, they're probably well over 1,000 pages. Clearly, I was disappointed when I found out I only had about 20 minutes. So, a big challenge. Anyway, what I'm going to try and do this evening is talk a little bit about the evidence now that has come up in terms of why we should be providing palliative care earlier and earlier in a patient's journey. And then I'm going to share some of the content of discussions that I've had with patients and families over the years. There are themes that keep coming up, and because they do, I think these are the important issues that patients and families want to speak about. Slide 2 is always a disclosure. I've got no financial or commercial interest to declare. I do have a morbid fear of public speaking, though. Seriously. Okay. 4 weeks ago, we had the privilege of listening to Dr. Harvey Chachanoff from Winnipeg and Dr. Brian Goldman from Toronto, and they talked in general terms about what palliative care was or is. I tried to save a lot of time by having the definition of palliative care looping through the intermission, so I hope some of you were able to review that. But very, very quickly, palliative care is an approach to care. It's a culture of caring. It's not restricted to a particular location. That can occur in a patient's home, in a hospital, in a hospice. People are even providing it on the street to street people. It can be combined with the active care of any patient with a life-limiting or life-threatening disease. It can be provided to people who are going through a very serious illness, yet recover. Remember, it's an approach to care. It's a culture of caring. A couple of quotes that really resonated with me a month ago. Harvey put this one up. What should I know about you as a person to help me take the best care of you that I can? And he repeated that a couple of times, and by the time I heard it the third time, I thought, you know what, you got my attention now, that's really important. What this basically is an open-ended question to a patient family, and it's going to open a dialogue, and it's going to take time. Palliative care is a very labor-intensive, dialogue-intensive practice. Actually, pain and symptom management is only a very, very small portion of palliative care. Lauren very eloquently described her journey with her husband and left us with this quote: "If you don't know your options, you don't have any." Again, the point I want to make about this is that this comes out of dialogue. Dialogue is central to palliative care. I'm going to try and provide you with a little bit of comic relief. The caption here is, "I know you didn't mean any harm, but at this hospital we never say a patient died. We say they took a turn for the hearse." Comedy aside, the point I want to make from this is, unfortunately this physician is very, very uncomfortable about talking about death. Physicians reflect the culture from which they come. We all do. And as a society, we generally have a very significant aversion to addressing death and dealing with it. A little bit strange considering we'll spend all kinds of money going to the movies, watching these very violent films, which, almost, there's a lot of gratuitous stuff in there that's unpleasant, all around death. Xbox games are the same. Not that I have any. But anyway, as a society, there is this problem. In the first half of the last century, death at home was a very common experience, and people were actually fairly comfortable with that. Death then moved into the hospital in the second half of the last century and became institutionalized. It was cleansed. It no longer happened at home. And as a result, we became less comfortable dealing with the notion of death. I hope there are no naturopaths in the audience, but they should not take offense to this. The caption reads, "Alternate medicine can do no more for you, Mrs. Smith. I'm sending you to a family physician." I would rewrite the caption here and say, and my apologies to Pablo Cano, "Medical oncology can do no more for you, Mrs. Smith. I'm sending you to a palliative care physician." Palliative care has an identity crisis, or an identity problem. We're seen as end-of-life care when truly we aren't. These two diagrams here sort of depict this problem. Under the traditional palliative care in the top, you can see that sorry. No, I edited this slide and the edits don't appear. So I'll work with it, it's fine. The top diagram shows palliative care as end-of-life care, what it's added on as the Professor Quack has said to Mrs. Smith, "I'm going to send you to a family physician." That is sort of an old model which really doesn't serve anybody's best interests. It only sort of promotes the notion that palliative care is true end-of-life care. In the second second diagram there, it shows that palliative care actually comes in to a certain degree at diagnosis and then assumes an increasingly greater portion of the patient's care as you approach death. What also is not shown on this is that there's an inverted triangle that's tagged on to the end of both of these models, which represents a bereavement period, which it's open-ended. So we're not only caring for the patient, we also continue to care for the family long past the patient's death. And we only get one chance to get this right. It's important that we get this right, not only for the patient, but for the family as well, because they are the ones that are going to live with their memories of how Uncle Jack or, Daddy Herb died. So why introduce palliative care early? I want to share with you some evidence that's been recently published, which is really quite exciting. This is an article from the New England Journal of Medicine. It's a very respected medical journal. It's kind of like National Geographic to the rest of us. Anyway, this looked at providing early palliative care for patients with metastatic lung cancer. They took about 150 patients that were diagnosed with metastatic lung cancer. That's cancer that's spread, that's going to be fatal, it's not curable. And what they did is they divided patients into two groups. One group had an early palliative care consultation. The second group had standard end-of-life referral, which would be that thing tacked on at the end. What they found was very interesting. Patients with early palliative care consultation had less depression, less anxiety when scored on the various scales. They reported a better quality of life. They received less aggressive treatments. There was actually less chemotherapy given to them because they didn't want it. Healthcare costs were lower, presumably because they didn't receive as much aggressive therapy, and there were fewer complications from treatment, so they stayed out of hospital. The bottom line, and this is really exciting, they lived 3 months longer. Now, when we compare new treatments to standard treatments, we use a plot like this. It's called a Kaplan-Meier. That's irrelevant. But what we do, we start off with 100% of patients alive at time 0, and as time moves across the bottom axis, fewer patients are on the plot because they die. Drug companies use this plot, and what they try and show is a divergence or a separation between their new therapy that's going to hit the market and earn them a lot of money and the old therapy. And the wider the diversion of these two lines, the more effective the new treatment is. Now, if I put this up here, I'm going to ask the question, how many of you would like this therapy? Okay, well, the answer is everybody, right? Because it shows that you live 3 months longer. But anyway, when this happens and drug companies sort of see this, they get excited. There's a press release. It's leaked. It appears in the Globe and Mail. It appears in the Wall Street Journal. Suddenly the stock markets get jittery and there's a jump in the stock prices for these companies. Very exciting, except it didn't happen for palliative care. Another article looked at patient expectations about the effects of chemotherapy in advanced cancer. They took almost 1,200 patients with newly diagnosed metastatic lung or metastatic bowel cancer. This would be stage 4. This would be disease that would be universally fatal, not curable. If these patients were alive 4 months later, receiving chemotherapy, they were provided with a questionnaire. And the questionnaire was to assess the prevalence of their belief that the treatment they were receiving was curable. Remember that this is patients with metastatic disease, which is fatal. 69% of those patients with lung cancer felt that they would be cured. 81% of those with bowel cancer thought they were going to be cured, and this is metastatic disease. Clearly, there's a serious misunderstanding here. This misunderstanding may compromise the ability to make informed treatment decisions. The decisions they make may be inconsistent with their preferences or their goals of care. Physicians may be able to correct this misperception, but it is often at the cost of the patient's satisfaction. You can imagine some of the comments that might emanate from a discussion like this. So one of the questions that was raised is, could early palliative care consultation improve the understanding of a patient's prognosis? This is another article that actually was published in December of last year from the New England Journal looking at early specialty palliative care. Their findings were that there was better symptom management, patients may live longer, there's a better quality of life, better quality of care, lower rates of depression, and they did find an improved understanding of prognosis, and these patients were less likely to receive aggressive chemotherapy at the end of their lives. So there's something up with palliative care. The edit is missing, unfortunately. There's another box that's coming out of the Grim Reaper's mouth that says, "There are no second opinions." I'm going to get Dan Lassard for this. I mean, that's they're not there. Okay. Okay. Now on to some of the recurring discussions I've had with patients and their families. I'm always asked about the pathway to death, and you'll have to bear with me that my frame of reference here is cancer-related care. I don't deal with chronic illness. So in advanced cancer, what you generally see is patients will begin to lose weight. This is because of a condition called cancer cachexia. It's not starvation. These patients will be eating, but they will be losing weight. It's a metabolic uncoupling of some of the processes that prevent them from extracting calories from the food that they eat. Down the road, their appetite becomes impaired. They lose their appetite. Their intake of nutrition falls off. There's a wasting of muscle. There's muscle loss, which translates into an increasing weakness. They can't move around as much. There's reduced activity. At some point then, there's reduced fluid intake and there's reduced urine output. The reduced urine output leads to a gradual accumulation of other wastes and toxins, which as they build up are going to have an effect on a number of other organ systems, including lowering of a level of consciousness and confusion. With the weakness, cough becomes ineffective, swallowing becomes more difficult, and the voice weakens. There's a confusional state which appears, we refer to that as being delirium. It tends to fluctuate. It's generally explained by either medication or changes in terms of other underlying organ systems. And with that, you can get a reduced level of alertness. Airway secretions tend to increase. Usually we can clear those if we're functionally intact, but these patients are losing that muscle strength, so the secretions pool in the airway. You can get that gurgling. I'll say more about that later. As the circulation in the skin begins to fail and retreat, you'll see cooling of the skin, mottling of the skin, And at some point you may see some issues relating to bowel and bladder incontinence. Not a pleasant thing to face. But sometimes knowing this is better than not knowing it. At some point, there is a cardiac arrest, and this occurs when there's complete cessation of all cardiac activity and respirations. It results from a failure of cardiovascular and respiratory centers that are located in the brainstem. The brainstem is sort of the lowest point of the brain where the spinal cord plugs in, just inside the skull. This happens usually as a consequence of multiple organ systems failing, particularly liver and kidney. There's an increase in the amount of acid load that's no longer being excreted. Potassium levels rise. And essentially, you've got a problem with impaired cellular function. Cardiac arrest is the final result. Cardiopulmonary resuscitation is a futile endeavor. And I don't know even why we think about it being an option at this point. That's not correct, though, in patients who may have a cardiac arrest from trauma or pure cardiac disease. In that setting, they generally got healthy bodies. Okay. But at the end of life, in advanced malignancy, CPR is futile. This is a depiction of the Ontario-wide Do Not Resuscitate confirmation form. This is the form that home care is very interested in getting their hands on. And so are physicians. But basically, what this is about is the patient's name goes on it. There are two options. Either the patient indicates that they do not want to be resuscitated at the end of life, and that's not going to be part of their treatment plan, or the physician declares that it should not be part of the treatment plan and that he's discussed this with the patient and or their substitute decision maker. There has to be informed consent with this. Healthcare providers can sign this, physicians, registered nurses, nurse practitioners, or registered practical nurses. Once the form is completed, this protects you from an attempt by emergency health services from reviving you if you're found without a pulse. So, another conversation surrounds what you need to do for preparing for death at home, because a lot of patients and families really want to leave the hospital and return to their homes. You do need a supportive spouse, you need a supportive family. Without them, this isn't going to happen. The physical surroundings at home need to be adaptable, or they need to be appropriate. In some homes, it's just not practical. You need the Community Care Access Center involved in nursing services. The DNR status has to be confirmed with one of those pages I've just shown you. CCAC will also provide an in-home pronouncement that's generally done by a registered nurse. A symptom relief kit is a package that contains probably around half a dozen different drugs, which are available in case of crisis management or a sudden onset of a symptom that needs to be dealt with right away. It's meant to support a patient for a few hours until further medication can be obtained through their pharmacy. Death at home is best accomplished when symptoms and pain are effectively managed. If you've got uncontrollable symptoms, or one of the slides later talks about unendurable symptoms, this is one thing that's going to interfere with the possibility of a death at home. You need 24/7 support around the clock from both nursing and medical backup. If you don't have that, if you have a crisis, it's not going to end very well. Patients and families need a backup plan. Possibilities might include a hospital or a hospice, but that's something that needs to be negotiated or discussed well ahead of time. A backup plan of going to the emergency room is not a good idea. The emergency room staff, as good as they are in managing major trauma and cardiac stuff, they're not very good at managing end-of-life symptoms. So you may find yourself in this situation. You may be spending your last few hours behind a curtain in a very busy, noisy emergency room. And I would submit that's probably not the kind of death that somebody would have envisaged, particularly if they'd started off wanting or planning for a death at home surrounded by their family. Do not call 911. If you call 911, you'll get a tiered response. And when the staff arrive, they're not coming for tea. They're coming to help you with an emergency. If you've signed already, or if there's a DNR status in place, then really a 911 call is not appropriate. This sometimes happens when a family member panics if they don't know what to expect. But we usually include it as an instruction: do not call 911. Hopefully funeral arrangements will have been made previously, and that will help you with transport of the body following death. Some of the barriers to a death at home: if you have fragmented home care services. Some parts of the province, in isolated areas, home care is very, very patchy, and this may not help. If you don't have 24/7 support from nursing or medical to help you in terms of a crisis management, that may be a problem as well. If there's family dysfunction, feuding siblings with different issues, different needs, or a caregiver who may be incapable, let's say they have a mobility issue or they may be in their upper 80s, things are not going to work very well in that setting. And then there's the issue of unendurable symptoms. Delirium. This is a confusional state which can be very frightening to family members, and when it occurs, it's one of the top reasons for patients being readmitted to hospital. Severe shortness of breath or low oxygen levels can be another reason why a death at home isn't practical. A bowel obstruction with persistent vomiting, that's number 3 on the list, and severe pain is probably not 4th, it's probably near the top, but it's another item. So in any of those 4 circumstances, the best laid plans may not bear out. There was a study was done a few years ago that looked at these 4 symptoms in patients who ended up being hospitalized, and at 48 hours, in about half of them, these patients required sedation for comfort. So that's probably why they do not occur at home. We deal with a constellation of symptoms. We deal with symptom clusters in patients with advanced cancer. This list here with the percentages came from a study that looked at patients with cancer pain who were referred to a pain clinic. It's not just enough to manage pain, you've got to deal with all the other symptoms that come with it. And as the patients, the severity of their disease increases, the frequency of some of these symptoms changes and increases as well. And some types of malignancies are actually, their symptoms associated with those are more frequent than others. Some of the potential interventions we can offer: we can provide drug infusions for pain or sedation. Sometimes a urinary catheter can be quite useful in patients who no longer can get up out of bed to get to the bathroom. Oxygen can be provided. Skin care is very important. Sometimes patients will require low pressure mattresses to preserve their skin. We can also provide nasogastric tubes for vomiting. This can be done in the home. This is probably the most effective, more effective than any drug for nausea and vomiting, actually. It simply just vents, drains out any fluid that may be pooling, and relieves that urge to vomit. And then paracentesis and thoracentesis, these are 2 procedures that are used to either remove fluid from around a lung or within the abdomen to relieve pressure. If the fluid is around the lung, it can contribute to a shortness of breath. If there's a lot of fluid in the abdomen, it'll elevate the diaphragm and also contribute to shortness of breath. Occasionally, I have done those in the home, but I don't think many practitioners would. But that's certainly something that can be done. Some hot button issues. These are the things that occur, and when they occur, there's a lot of grief that comes with them. Nutrition. Some family members will look at their loved one and they see that they're not eating and that they're losing weight, and their assumption is, oh my gosh, he's starving to death. Well, in the setting of advanced cancer, this is cachexia. And we actually know that even if we provide artificial nutrition through intravenous feeds and that sort of thing, these patients will still lose weight. So feeding it's a question of looking at it from the patient's perspective, not the family perspective. And I tend to sort of provide that to them. I said, you know what, you're thinking about what it's like for you when you're hungry and not eating. In this setting, Uncle Joe or whoever, he doesn't really have much of an appetite. He's not going to experience hunger in the same fashion. Same thing about hydration. There's an idea that patients will become thirsty because they're not drinking or their liquid intake is poor, and that must be terrible and would be a horrible way to succumb to their illness. The truth is, nature does this to us. There's a natural process that nature goes through where the body tends to shed fluids, and we get ready for dispatch, so to speak, having shed a few pounds of fluid. If we run against that by providing hydration, we will contribute to increased swelling of limbs, of the skin. It actually contributes to a lot of increase in terms of the airway secretions as well. So, hydration doesn't really make a difference in terms of quality of life. If anything, it makes it worse. We sometimes will use a bit of hydration for a few hours at a time if we're trying to clear some of the toxins through kidneys. That's a complicated thing, but we might sometimes do that. But anyway, airway secretions. You get this gurgling sound as somebody's breathing, and the family hears this and they say, "Oh my goodness, are they going to choke?" Well, the answer is no. What's happening is that these secretions are sort of bubbling back and forth in the trachea. If you've ever snorkeled or scuba dived and got a little bit of water in your snorkel and you get that sort of bubbling sound, it's exactly the same sort of thing. I provide reassurance that this is just a bit of mucus. It's sort of moving back and forth. They're not going to choke. It's more of an annoyance. There are some medications we can give to dry that up, but usually with a bit of an explanation, they're okay with that. Pain pumps. This problem is, pain pumps we use to deliver a consistent rate of a pain medication. And we also provide an opportunity for the patient to give themselves an extra dose if they feel they need it. It has to be patient-controlled. Unfortunately, family meaning well will sometimes seize the plunger and then start administering extra doses when the patient may be asleep and they moan and they think that's pain. The net effect is that the patient gets far more pain medication than they need, and this leads to a syndrome of restlessness, twitching, like a delirium, and that doesn't have to happen. So I spend a bit of time and explain this to family, that it's their patient that does this. They don't need to help them. Delirium, it can be a very frightening condition to watch. There's a spectrum of activity. Patients can have delirium and be very, very still and not move. Others can be very, very hyperactive, moving around, moaning, screaming, essentially hallucinating and reacting to what they think they're seeing. That can be frightening to families. It's one setting where we do can use some sedation, but a gentle explanation in terms of what is going on generally looks after their, or at least reduces their anxiety and fear. I frequently get asked about organ donation. In cancer patients, this is really restricted only to corneal tissue. Cornea is the tissue in your eye that you put your contact lens in against, okay? It does not have a blood supply. So it's impossible for any solid tumors to spread there. That's why it's ideal tissue. Sometimes there are other disqualifying conditions like hepatitis or some of the degenerative neurologic conditions that might preclude donation. Patients with lymphomas or leukemias cannot donate eyes. If you're looking at transplant, we generally try and harvest within about 12 hours with a blood sample. Other options are using eyes for teaching or research purposes. How bad is it, doctor? Should I start dating? Do you want me to answer that? Well, the question is probably, if the patient's asking the question, it should be, how long do I have to live? If the question's outside the room is, how long does he have to live? So how long do I have to live? As physicians, we frequently overestimate survival. Survival rates apply to groupings of patients, not individuals. Because of related complications from malignancy and disease progression, which is completely unpredictable, this sort of skews our estimates and leads to an overestimate. What's been introduced in the UK and has made its way across the Atlantic is a surprise question. Would you be surprised if this patient would die in the next 6 to 12 months? If the answer is no, we're trying to use that as a trigger to refer the patient or at least consider invoking palliative care. We've been having patients score their symptoms at cancer centers in Ontario since 2006, 2007. We've also been looking at their performance status. And a performance status basically is a chart or a score that tells us about the physical capacity of that individual, their ability to move and that sort of thing. And I just want to highlight the 70% down to the 30%, where it's regarding ambulation, it's reduced. It then drops to patients mainly sitting or lying at 50%, and they become totally bedbound at 30%. So going back to the question of how long do I have to live, this graph here starts at the last 26 weeks of life. These are for Ontario patients seen at cancer centers who have completed this palliative performance scale that I just showed you. At 26 weeks, they start off at about 70%, which means they're fully ambulatory. By the time they get to 50%, which the arrows aren't showing here, unfortunately, when they get to 50%, they're at about 2 to 3 weeks in terms of survival. When they get to 30%, they're about 1 to 2 weeks. So by the time they're fully confined to bed, time is running out quickly. A couple of comments. That's too late to start making your end-of-life plans. It's too late to begin all the dialogue about palliative care. But it may give us a bit of a clue in terms of what's actually happening to a specific patient in terms of their survival. This website is actually in the brochure. I would encourage you to go to it. It's very well organized. There's an exercise on it where you can download a workbook and work through it with your friends, family, relatives, etc., whoever your family is. And it'll takes you through this complete exercise of end-of-life planning, advanced care planning, rather. Very quickly, this is an Australian paper, appeared in the British Medical Journal, which is not quite as good as the National Geographic. But anyway, this looked at the impact of providing advanced care planning on end-of-life care to elderly patients. Patients were grouped into two groups. One received the usual care, or the other group received usual care plus facilitated advanced care planning. And that advanced care planning was aimed to assist patients to reflect on their goals, values, and beliefs, to consider future medical treatment preferences, what they wanted, what they didn't want, to appoint a surrogate, or in our case here, a substitute decision maker, and to document their wishes. Briefly, their conclusion was that a coordinated systematic model of patient-centered advanced care planning using non-medical facilitators assists in identifying and respecting patients' wishes about end-of-life care. It improves such care from the perspective of the patient and the family, and it diminishes the likelihood of stress, anxiety, and depression in surviving relatives. Remember what I said about we only have one chance to get this right because it's the family that lives with the memories. This is really important, being part of that. So surviving relatives actually were able to make some comments to questionnaires. I'm just going to list some responses from both groups. So this is from the intervention group that had the advanced care planning. His death was really peaceful and everyone knew what to do. We had a clear plan so could just relax and enjoy time with Dad. Even though we already knew what he wanted, it was great to be given the opportunity to talk about it and get it out into the open. We really felt comfortable making decisions because we had discussed it with him. He had a very peaceful death, just as it should have been, and I would like to thank all staff for this. Now, there's a very nice tenor to that. Compare this with the control group. He knew he was dying and it was very hard for him. We should have talked with him about it. He should have had more say. He couldn't do the rehabilitation. He knew he was dying, but the doctors just didn't seem to get it. The hospital has a responsibility to talk with patients about these things. My sister never got a say, and that was wrong, or that is wrong. They wouldn't let her go. They kept doing tests and things she would not have wanted. Mom didn't want heroics. She knew she was dying. I was horrified when I heard she got 45 minutes of CPR. She did not want it. All anyone had to do was ask. I feel very hurt, and hurt for Mom and my sister. So quite a difference in the two, and you can see there, these families are going to carry these memories forward for the next generation. It's going to color their views on end-of-life care. Yeah, this is part of the right, yeah, this is supposed to be here. I have a few personal heroes. Chris Hadfield is one of them. And I actually really enjoyed reading his book. And he has some advice to us earthlings on end-of-life care, and I'm going to read it to you. While I very much hoped not to die in space, before my last space flight I reviewed my will, made sure my financial affairs and taxes were in order, and did all the other things you do if you knew you were going to die. But that didn't make me feel like I had one foot in the grave. It actually put my mind at ease and reduced my anxiety about what my family's future would look like if something happened to me. Which meant when the engines lit up at launch, I was able to focus entirely on the task at hand, arriving alive. When I read this over New Year's, I thought, oh God, this, what a perfect quote. So anyway, thanks to Chris. I'd also make the point here that, if we look at how we may die, 10% of us are going to have a sudden, unexpected death that might be related to trauma, or it might be related to cardiovascular disease. We might end up spending a few days in the ICU on a ventilator before we die. I think given that, it's very important to undertake this advanced care planning, because you just don't know when the penny's going to drop. The other 90% of us are going to have a little bit more reprieve. We're going to live a long time or a longer time with our chronic illnesses. But still, I think it behooves us to do this. I was going to leave the last word to my friend Oscar here. And Oscar says, don't bury your head in the sand like an ostrich. Let's talk about advanced care planning and palliative care. Anyway, thank you.